la voz experta de la asociación. En Radio AMEDLA ya tienes la solución.
Welcome to Radio AMEDLA, and a very warm welcome to the Deep Dive.
Hello, everyone.
Today we are taking a surgical scalpel to the foundational knowledge that Dr. Javier Enrique Celis Silva laid out for us on Mucogingival and Peri-implant surgery.
Yeah, this is our shortcut. Our mission for this deep dive is to pull out the absolute core theory, the clinical applications you have to know, and some of those really surprising techniques that make all the difference.
Right, we're talking everything from aesthetic crown lengthening all the way to really complex defect repairs.
We have a lot to get through.
We do. So let's jump in. And a quick welcome to all our listeners, all our meddlers. Just before we get technical, a quick announcement for you.
Oh, yeah.
Don't forget, you can catch our monthly webinars live over at www.twitch.tv/AMEDLA. Definitely give that channel a follow.
And if you miss one, they're all archived. All the past webinars are up on our YouTube channel, which is www.youtube.com/AMEDLA official.
That's right. And for our international audience, we're working hard to get all of that amazing content subtitled and even dubbed into English.
A huge project, but it's happening.
Okay, so let's get into it. The presentation was from Dr. Celis, a licensed dentist from UNEM Iztacala, a really well-known periodontics expert. And he started right at the beginning with the periodontium itself.
Exactly. You can't operate if you don't know the environment. So just as a quick review for everyone, we're talking about the four supporting tissues. You've got the gingiva, the periodontal ligament, the alveolar bone, and the cementum.
And periodontal plastic surgery, as he defined it, is all about working with those tissues.
Right. The procedures are aimed at one of two things. Either prevention, so say gaining more keratinized tissue to prevent future problems, or direct treatment of defects that are already there, functional or aesthetic.
And he really hammered this point home. Diagnosis is everything. It's the core.
It is the absolute core. It dictates everything that comes after. You misdiagnose, you're patching a problem, you're not solving it.
And when it comes to aesthetics, especially in the front of the mouth, he pointed to one non-negotiable landmark: the zenith.
Yes, the zenith.
So the zenith is the highest point of the free gingiva. Why is getting that one little detail so critical?
Because the eye picks it up instantly if it's wrong. The zenith has to be slightly inclined distally, so away from the midline. If you don't respect that, the whole result looks off.
And there's a hierarchy to it, isn't there?
A very strict one. For procedures like gingivoplasty, the central incisors, and the canines, their zenith should be on the same level, but the lateral incisors have to sit about 1 millimeter below that line.
Just 1 millimeter.
1 millimeter. If you ignore that, the smile looks heavy. It looks unnatural, even if the tissue is perfectly healthy. It's a game of millimeters.
It really is. Okay, sticking with precision, let's clarify the relationship between soft tissue recession and bone loss.
It's a big one.
A vital distinction. So, gingival recession, that's when the gum line physically drops down the tooth. It always means there's been some alveolar crest dehiscence. The bone underneath is gone. Always, but not the other way around.
Exactly. The reverse is not true. You can have bone loss, a dehiscence, without any visible recession. It can be hidden, especially under thicker tissue types. And this is critical because when you see recession, you know you're dealing with a complex repair.
Yeah.
You've lost both hard and soft tissue volume.
So it's a definite red flag for complexity. Okay, let's talk about the tissues themselves. He reviewed the free gingiva, the papilla.
Right, the attached or keratinized gingiva and the mucosa. And he was quick to point out that the papilla, the little bit of gum that fills the space between teeth.
The thing that prevents black triangles.
Yeah, that is notoriously difficult to regenerate. He even gave a shout out to Dr. Javier Gomez Rocha's work using hyaluronic acid for that, which is really specialized stuff.
But the real workhorse tissue for stability, the one we really need, is the keratinized gingiva.
That's the one. It's that firm, fibrous tissue that gives us stability. It's protective.
Which brings us to a bit of a debate in the field, right? How much of it do you actually need? Some say 2 to 3 millimeters is enough.
Yeah, you'll hear that. And look, for a basic flat procedure, maybe 2 or 3 millimeters will get you by in the short term.
But Dr. Celis seemed to advocate for more.
He did, because it's about the long-term prognosis. If you can get 4 to 5 millimeters of that really robust, firm, keratinized tissue, you dramatically reduce the risk of future recession. It's a much more stable barrier against, toothbrushing or the pull from a frenulum.
So it's not about what's sufficient, it's about what's optimal. You're future-proofing the result.
That's the perfect way to put it. You're aiming for predictability.
So why do people lose this tissue in the first place? What are the common causes?
Well, the number one driver is always going to be biofilm accumulation, periodontal disease. That's the big one. But you've also got these key secondary factors.
Am I brushing too hard?
Traumatic toothbrushing, absolutely. Occlusal trauma can play a role too. And then you've got anatomical issues, like an aberrant frenulum that just keeps pulling on the tissue margin.
And you brought up a fascinating systemic link. A patient who developed really severe fibrotic hyperplasia after a COVID-19 infection.
That case was an amazing illustration of a clinical reality we can't ignore. Systemic inflammation from something like a virus doesn't just stay in one part of the body. It can show up directly in the mouth, causing this kind of intense, unusual tissue overgrowth. The mouth isn't isolated.
It's a powerful reminder. Okay, let's move into the surgical techniques, but first, the prerequisites. What were the absolute non-negotiables before picking up a scalpel?
First, obviously, no surgery on a healthy periodontium. You don't fix what isn't broken. Second, systemic issues have to be managed. Uncontrolled diabetes is a concern, but the absolute red flag he raised was bisphosphonate use.
And that's because of how the drug actually works biologically.
Exactly. Bisphosphonates inhibit angiogenesis. They stop the formation of new blood vessels. In surgery, that's a disaster. It cripples healing and can lead directly to osteonecrosis of the jaw. It just changes the entire risk-benefit equation.
And of course, the mouth has to be clean.
Oh, absolutely. Phase 1 periodontal therapy has to be done. You need that biofilm level below 20%. He even mentioned the whole mouth debridement technique, which is a great way to just knock down the entire bacterial load in one go.
Okay, so the stage is set. Let's start with a common one, gingivectomy and gingivoplasty.
Right. This is for things like tissue overgrowth hyperplasia or for aesthetic crown lengthening. This is often the procedure that gives that wow factor, that instant aesthetic result.
But again, it all comes back to precision.
All back to the zenith. You have to respect those heights. Centrals and canines aligned, laterals 1 millimeter down. Get that right, and the results are beautiful.
Now for the bigger stuff, recession coverage. The gold standard is the autologous connective tissue graft, the CTG.
Still the gold standard. It's the patient's own tissue, usually from the palate, and it just gives the best long-term stability. And he shared a fantastic little clinical pearl about handling it.
Was that?
Because the graft is slippery and it's full of blood, it's easy to drop. So he recommends pre-suturing it, putting a stitch in it while it's still partially attached to the palate. It gives you a tether, a handle. It's pure clinical wisdom.
That's a great tip. Okay, let's talk biology. How does this piece of tissue actually survive in its new home?
This timeline is so important to understand. For the first 1 to 3 days, the graft is barely surviving. It's living off of what's called plasmatic circulation, just sort of soaking up nutrients from the periosteum underneath it.
So it's very vulnerable.
Extremely. Then around day 4, true angiogenesis begins. New blood vessels start to grow into the graft, helped along by the fibrin matrix, and it finally becomes a vital living part of the new site.
And when we use a coronally displaced flap, or CDF, to cover that graft, we're fighting against biology's tendency to shrink.
That's right. It's a known phenomenon. Those flaps will retract about 1 to 2 millimeters as they heal. So the clinical tip is simple. You have to overshoot. Aim for 1 to 2 millimeters more coverage than you actually want on the day of surgery.
Because if you aim for perfection on day 1, you'll end up with a defect on day 90.
You will, without a doubt.
Okay, what about alternatives to the patient's own tissue? He mentioned a few, starting with Derma, the porcine matrix.
Right. Derma, it's a porcine and acellular dermal matrix. Very effective, but it comes out of the package quite rigid. And if you try to work with it like that, it'll tear the flap you're trying to cover it with.
So you have to prepare it.
Mandatory hydration. 30 minutes in saline solution. You have to do it. It makes it manageable.
That's a big logistical step, a half-hour wait in the middle of a surgery.
It is. It requires planning. You might have your assistant start soaking it before the patient is even fully prepped, but if you skip it, the procedure can fail right there.
And what about the human cadaveric matrix, Alloderm?
Yeah.
There was a huge safety point with that one.
A critical one. Alloderm is great, but it's processed with antibiotic therapy, specifically penicillins. So you absolutely must check for penicillin allergies in your patient's history. It's a life-saving checklist item.
Wow. That detail alone is worth the whole deep dive.
Right.
Okay, and quickly, matrice derm.
That's a newer one. The big claim from the manufacturer is that it can actually be left partially exposed as long as the underside is well vascularized. That could be a huge advantage in some really tricky cases.
Interesting. Okay, let's shift gears to some more specialized procedures. Correcting a gummy smile with lip repositioning.
Yeah, the Lipstat procedure. This is super effective, but patient selection is everything. It only works if the gummy smile is from a hypermobile lip, a lip that moves too much, and not from, say, the maxilla being too long. That would be a different surgery entirely.
How does it work physically?
It's actually pretty straightforward. You make an incision deep in the vestibule, remove a strip of mucosa, and then you suture the top edge down to the bottom edge. You're basically creating a physical barrier that stops the lip from riding up so high when they smile.
And again, immediate results.
Which patients absolutely love.
Right. How about gingival depigmentation or peeling?
Purely aesthetic. It's for removing melanin pigmentation. You can do it with a scalpel or a low-speed rotary burr. The one thing to tell patients is that it can come back. The melanocytes are still there. It might take months, it might take years, but it can return.
Good to manage expectations.
Yeah.
Okay, let's get into peri-implant management. This is where it all comes together. He showed a case where an implant was showing through the gum.
Yeah, you can see the gray of the titanium. It's a classic thin biotype problem. The first step there is debridement, but you must, and I mean must, use plastic curettes.
Why plastic?
Because a metal instrument will scratch the titanium surface, and that surface roughness is essential for maintaining osseointegration. You damage that, you could jeopardize the entire implant.
So you clean with plastic, and then you have to build up the thickness.
It's a layered approach. You put in a bone graft to fix the underlying bone defect, then a collagen membrane, and then you top it all off with a soft tissue alloplast like Derma to bulk up the tissue and hide that gray shadow.
It's like building a wall layer by layer.
That's a great analogy.
Finally, he showed this beautiful example of using these techniques outside of pure periodontics. Sealing and oroantral communication, an OAC.
This was my favorite part. It just showed the incredible versatility of these skills. So this is a hole between the mouth and the sinus, usually after a tough extraction. And to seal it, he used a precise, multi-layered repair.
Take us through those layers one more time. It was so specific.
Okay, so from deepest to most superficial, layer 1 at the very bottom is the connective tissue graft. That's your main structural seal.
Okay.
Layer 2, right on top of that, is fibrin or spongastan. This is the key. It acts live during those first critical 3 days.
Right before the blood vessels get there.
Exactly. Then layer 3 is the bone graft to rebuild the hard tissue. And finally, layer 4 is the collagen membrane. And its job is to be a barrier. It stops the fast-growing skin cells from filling the space, giving the slow-growing bone cells a chance to do their work.
What an incredible combination.
No.
It solves a huge functional problem, all with soft tissue protocols.
It's just fantastic. It really shows how this is a blend of art like getting the zenith just right and pure biology, like understanding how a graft gets its blood supply.
A perfect summary. The whole field is about creating predictable outcomes, and that comes from respecting the biology.
It does. And on that note, we'll leave you with one final thought to chew on, something that really ties a lot of this together.
What should our listeners be thinking about?
Okay, so considering that we often see bone loss and soft tissue recession together, think about this. Why is the strategic priority in so many of these advanced cases to first gain adequate soft tissue thickness with a CTG before you even attempt to graft the bone underneath?
So why soft tissue first, then hard tissue?
Exactly. That sequence, that decision, dictates the long-term success of the whole thing.
An excellent strategic question to ponder. Thank you for joining us on this deep dive into the work of Dr. Celis Silva. It was incredible.
A pleasure. And before you go, please follow AMEDLA on social media and share this with your colleagues. It's how we all get better.
And don't forget, you can register for our free monthly webinars and, of course, affiliate with us through www.amedlasa.org.
We'd love to have you.
And just a final reminder that the certificates AMEDLA issues have official curricular value from the CEP, the Secretariat of Public Education in Mexico. Thank you for taking the time to get well informed with us.
Until next time.